Hi Academy team, and welcome to another presentation on oral medicine for your grand round presentation that you had on Monday. We are again learning from Dr. Lalima Tiwari, the oral physician who you know by now, and Lalima is going to explain the answers to the three fantastic cases that you've seen. And like I say, always say, the cases that we pick are the ones that you come across in your clinic, sometimes at the end of a very busy day, sometimes right before the long weekend on a Friday evening, and you don't know exactly what to tell the patient, and you don't know what to do and how urgently you need to treat this patient or refer this patient, or how you need to treat the patient. So these are the cases that we see from streamline of general practice, and we like to learn firsthand from the experts to know what's the best way to provide the best care to our patients. So, and Lalima has also prepared a lovely presentation of a case which was not in your quiz, about another hot topic, which I keep it as a surprise for now. At the end of the three cases from the quiz, we go through the surprise case as well. So an extra learning for tonight. Good evening, Lalima, and to you.
Hey. Hey, Saul. Thank you again for having me this week. So this time round, we're going to cover a few more oral conditions, and then also another case that can definitely present to GPs around Australia, where sort of you're the first line management. What are you going to do with that one? So I'll also keep that as a surprise. But we'll move on to case number one to begin with, which was in fact a ulcer on the lateral tongue. So a 43-year-old male who presented with a 10-day history of acute pain from his tongue. He wasn't sure if it was in fact improving or not, and he recalled waking up one morning and potentially may have bitten his tongue that night, but he wasn't entirely sure. And his medical history overall insignificant, but moderate obstructive sleep apnea, which was managed with CPAP therapy. And in this case, you can see that there is a 7 by 5 millimeter ulcer that was in fact firm to palpate, and it has this keratotic margin with rolled borders as well on the lateral tongue. So before we actually jump into the first question, which was describe or list the differential diagnosis for this particular case, some clinical tips when actually evaluating mouth ulcers is the first thing is to consider the duration. So how long has the ulcer in fact been present for? Is it an acute ulcer or is it a chronic ulcer? And the threshold that you should use is 3 weeks. So if an ulcer has been present longer than 3 weeks, you're looking at a chronic ulcer. And if it's less than that, it's still in the acute stage as well. The second thing is if the patient can provide you any history of possible triggers for that particular ulcer. So is there possible trauma? So in this case, they may very well be. Has the patient in fact started any new medications and then developed a ulcer? Similarly with any oral hygiene products or certain food and drinks that may have in fact triggered their mouth ulcer to have occurred. Finally, you want to decide as well, is this just a solitary ulcer that you're dealing with? Is it in fact multiple, or is the ulcer recurrent as well? And then clinically, when you're evaluating the ulcer, you want to decide, obviously having to look at the location of the presenting ulcer. Now, interestingly, the lower labial mucosa, so inside the lip or within the cheek as well, the buccal mucosa are one of the more common places for mouth ulcers to occur. The tongue, you actually really have to sort of injure it quite significantly to develop the ulcer. So the thickness of the epithelium around the tongue and similarly on the hard palate are a lot thicker than the buccal mucosa, so inside the cheek and around the lips as well. So for someone presenting with an ulcer on the tongue or on the hard palate, you may want to consider other possibilities as to why is this ulcer, what's happened to create the ulcer in such a thick epithelium. Similarly, you would note the size of the ulcer, and you also want to assess the background of the ulcer as well. So not just purely the ulcer or the break in the epithelium that's there, but have a look at the surrounding tissue. So in this instance, you can see quite a lot of white appearance around the ulcer itself. So that's that keratotic appearance. And then also you can appreciate that the margins are quite raised and rolled. So that's something that you again want to note, because in this instance, these are the features that you'll be recording for the patients, and different ulcers definitely have different presentations. The final thing clinically that it's really important to do is to palpate the ulcer. So actually feel the ulcer with your tongue, and what you're looking for there is whether the ulcer is in fact soft to feel or if it is firm to feel. Any sort of firmness to an ulcer is a bit of a red flag, and that's definitely something you need to make a note of and review for later on as well. In the presentation of a chronic ulcer, and if it is firm, that's again two red flags, and that patient may need an urgent referral for management. So these are certain clinical clinical tips that you can use when a patient in fact presents to you with a mouth ulcer. So using those I guess, clinical tools, we can then decide, for instance, in this case, the patient has only had the ulcer for 10 days, so you can definitely consider it as an acute ulcer. It is also solitary, so there's just one ulcer present. And so in that instance, your differential diagnosis can include traumatic ulcer. Another condition is called necrotizing xylometaplasia, which is very rare and generally occurs on the hard palate as well. So something like that to happen on the tongue is extremely rare, and you wouldn't really consider it as a differential. The other thing, however, in this instance is because it has only been 10 days, you can't completely rule out a chronic ulcer either. So as part of your differential diagnoses, you'd also need to consider the list of chronic solitary ulcers, which can vary from long-standing traumatic ulcers to eosinophilic ulcers, even SCCs, and then also syphilitic ulcers as well. So you can't just sort of dismiss the patient and be like, oh, you've just bitten your tongue and you'll be fine, because you actually need to ensure complete resolution of the ulcer to ensure that you've completely excluded these other chronic solitary ulcer conditions as well. So the next question would then be, what investigations are required to in fact achieve the correct diagnosis? So in this case, the first instance is to differentiate between an acute or a chronic ulcer. So firstly, the patient will need to be reviewed. And so the only thing that you're going to do at your initial consultation is in fact take a photo. The best thing you can do is take a clinical photograph of that ulcer, either upload it to the patient file for reviewing later on, or these days there's lots of different mobile applications available as well that you can take a clinical photo and save it safely on your phone, which is protected as well. And just, I guess, sneakily, I'm going to put in a little plug here for an app that we have in fact created called Oral MedMate, which is an app that is a clinical tool where you can plug in the different patient history and clinical findings, and it helps you determine a differential diagnosis at the end of it. You can also take photos and save it as a clinical case and set a reminder for later on as to maybe 2 weeks' time. It will remind you that you have a case to review. So further on as well, you can also consider referring through the app to any oral medicine specialist in Australia. So if you have some time, be my guest to try it and see how you find it with any particular oral condition that may in fact feature for you. But like I mentioned, there are many other ways of storing clinical photographs these days, whether it's proper clinical photography or simply on your phone as well. But the thing that you want to do here is take a photo of that ulcer, and you're going to then review the patient. So what is the appropriate management? The first thing is you definitely want to treat it as if it is an acute traumatic ulcer. In this instance, the patient has indicated he may have bitten his tongue, while being asleep. So ensuring that you've eliminated any local irritants, there's no sharp teeth, or the denture itself, if the patient is wearing a denture, is not irritating the area. Sometimes we actually recommend patients keep their dentures out for the whole 2 weeks as best as they can so that we can completely ensure there's no trauma, no further trauma to the area. You would also consider recommending an antiseptic mouth rinse or a gel for the patient to use. We don't usually recommend any steroidal based ointments or gels at this stage because technically any sort of traumatically or reactive ulcer is going to heal up on its own. So the antiseptic mouth rinse or gel is really to ensure that it doesn't get secondarily infected, which then can further delay the healing of the ulcer. So simply, the patient can use a chlorhexidine mouth rinse. There's brands like Savicol, for example, that's available in Coles, or another brand called Curacept, which is in the pharmacy. A patient can even consider using chloroflor gel, which is a bit stronger concentrations, 0.2% chlorhexidine, and they can directly apply it to the ulcer as well. And you get them to do this twice a day, every day until your next review with the patient. So they're essentially treating the ulcer as if it's a traumatic ulcer until they're due for the review. And that is a very important thing, is that you have to review the patient. Please don't dismiss them, ensuring that the patient will be able to follow up on the healing of the ulcer, because quite a few times patients may in fact think that it's improved, but the ulcer is in fact still present. So you definitely need to ensure that the ulcer has resolved. If the ulcer has not resolved, that's when a referral to either a max fax, oral medicine specialist, or a head and neck surgeon, a biopsy is considered. But if the ulcer has resolved, you know that it's a reactive ulcer, no further management is required. So that's how I would recommend treating the first case and differentiating between an acute ulcer and a chronic ulcer as well. So case number 2 was a scenario where a 73-year-old female complained of swollen and bleeding, painful gums. She also reported sensitivity in her mouth when eating spicy foods and when trying to brush her teeth as well. And also she noted that sometimes her oral symptoms would improve, but then they would recur again. Her medical history is significant for hypertension, and she's on some antihypertensives for this. And clinically, you note significant ulcerations on the hard palate, both bilaterally, and then you also notice, quite a lot of erythema and so inflammation and some reticular striations on the gingiva as well. So the question was, what are your differential diagnoses? In this case, you're looking at, in the chronic ulcer scenario, but we're dealing with multiple ulcers. So this actually takes you to a list of immune-mediated inflammatory conditions that can affect the mouth, and they can all present very similarly and can be quite difficult to differentiate between. The other thing, though, that's not listed here is, in fact, lichenoid drug reactions, and that, again, you can consider as part of your history taking as well. If the patient has, in fact, started any new medications, a lot of antihypertensive medications can, in fact, result in drug reactions like this in the mouth. So if there is a time-related factor, that may be a consideration as well to have. So we're generally dealing with, in terms of differential diagnoses, though, immune-mediated inflammatory conditions, and in this instance, possible lichenoid drug reaction as well. So the most likely diagnosis, though, in this case, because I didn't actually give you any hint about timing, is, in fact, oral lichen planus. Now, there's certain things that can differentiate clinically when you are looking in the mouth with oral lichen planus compared with other immunobullous conditions, and that is, in fact, these reticular striations. So there's almost like this mixed whitish appearance along with the ulcer and the erythema in the background. So if you do notice any of these particular changes in the mucosa, it is more likely to be oral lichen planus compared to, for example, pemphigus vulgaris or mucous membrane pemphigoid. which are more blistering conditions. Having said that, reticular striations can have been seen in other immunobullous conditions as well, so it's not a hard and fast rule, but more common than not, it is quite often associated with lichen planus. So what investigations are in fact required to achieve the correct diagnosis? In this instance, I would actually recommend an urgent referral to an oral medicine specialist or a dermatologist. And the reason for that is, as part of the differential diagnoses, you do have other immunobullous conditions that are being considered. And some of them are progressive and can in fact be life-threatening, for example, pemphigus vulgaris. So for that reason, I would in fact suggest an urgent referral so that the patient can be appropriately diagnosed. And with diagnosis as well, what usually happens is that the patient has two separate biopsies. One is from the lesion itself, and that is sent for histopathology to confirm the diagnosis and also check for any dysplastic changes. And the second is actually a perilesional tissue sample that's taken. So what you're aiming for there is in fact intact epithelium and not an ulcerated sample. And that particular tissue sample actually goes for direct immunofluorescence testing, which is the gold standard way of testing for immunobullous conditions. So you're actually doing a disservice to your patient if you just decided to take a tissue sample from the lesion and sending that for histopathology, because that is not, in fact, a good way of differentiating your other immunobullous conditions. So for that very instance, I would actually recommend a referral to a specialist for diagnosis. The patient also undergoes serology testing as well, specifically checking for pemphigus antibodies and pemphigoid antibodies and other ENA and ANA as well. So in this instance, the patient did in fact have histopathology and direct immunofluorescence confirmed for oral lichen planus. The third question for this case was, what other extraoral sites can be affected by this condition? So the reason why I, in fact, put this question in is because many clinicians forget, whether it's dental or medical, they forget that lichen planus can actually present extraorally. And in fact, it can be one of the initial presentations for patients, and they then go on to develop it in their mouth as well. So what studies actually show is about 40% of patients will have extraoral lichen planus, and that is quite often presented with their oral condition as well. So the most common extraoral sites that are affected are in fact the nails and the skin. With regards to skin manifestations, lichen planus can often get confused as eczema or psoriasis. And so the recommendation is that the patient is examined by a clinician who does have a background in dermatology, especially in the context of them suffering with oral lichen planus as well. So if they have been diagnosed with oral lichen planus and it appears that there are skin rashes presenting, it is important that the patient gets assessed from the context of lichen planus here. In fact, only 15% of cases will only ever be isolated in the mouth itself. So it's very rare that a patient will purely have oral lichen planus. More often than not, they will have other extraoral manifestations. So it is important to understand that it is a full body systemic condition that can present. Another presentation is obviously in the genitals. So vulvovaginal presentation is quite common. And again, it is one of those clinical presentations that can be quite difficult to properly assess and diagnose. And quite often, it's actually histopathology that is most reliable for these patients. It is very important that genital lichen planus isn't missed, because it does in fact carry a risk of malignant transformation as well. So again, in these instances, assessment done by someone who has a background in dermatology or even gynecology can be considered, especially in a patient who is complaining of recurrent genital irritation. And further, again, if they've already been diagnosed with lichen planus in other part of the body and are complaining of that symptom, that definitely needs to be assessed as well. The scalp and the esophageal areas can happen, but are quite rare to occur. And with regards to scalp manifestations, it can actually result in alopecia for the patient as well. So you can see that lichen planus is not just purely oral lichen planus, although a lot of dentists would like to tell you that it is purely oral. There's lots of systemic manifestations, and patients can often, with these extra oral sites anyway, it can take quite some time for them to be diagnosed with lichen planus because there's so many clinical manifestations that can look similar to other conditions as well. So it's just important to be aware of this. So with regards to the management, or the best management for this patient, again, given the ulcerations and the significant ulceration that the patient presented with, I would recommend a referral to an oral medicine specialist or a dermatologist for appropriate diagnosis and management, because the nature of this condition is that it is in fact chronic. Also, if you are suspecting genital manifestations, you can consider a referral to a gynecologist as well. In the meantime, you can consider empirically starting the patient on a topical steroid mouth rinse to help with the symptomatic management. So given the generalized ulcerations that were present for the patient, they can in fact make a compounded dexamethasone mouth rinse. So one of the concentrations is your 0.1 milligram per mil dexamethasone mouth rinse, and you advise the patient to rinse this 2 to 3 times a day for a minimum of 3 minutes. Anything less than that is not actually adequate enough to be absorbed through the mucosa, and they continue this every day until their symptoms in fact resolve. So for our particular patient, I did in fact commence them on this, and it took them about 2 to 3 weeks to feel better in their mouth. The other recommendation can also be to change their toothpaste as well to a sodium lauryl sulfate-free toothpaste. Quite often, your regular toothpaste like Colgate or Oral-B will contain SLS, which is quite an irritant for patients suffering with lichen planus. And so a simple switch can in fact improve their symptoms as well, especially when brushing their teeth. A recommendation of having good oral hygiene and seeing their dentist regularly in any patient with oral lichen planus is important, but particularly if they have lichen planus affecting their gingiva. And the reason for that is that the patient is actually more susceptible to periodontal disease and gum recession as well. So especially in those instances, it is important to encourage the patient to see their dentist on a regular basis. The other thing is the patient does need to have ongoing surveillance with the oral medicine specialist that they're seeing every 6 to 12 months. And the reason being is that lichen planus in the mouth does carry an approximate 1% risk for transforming into mouth cancer. And like we mentioned last week, oral cancer doesn't present necessarily as your classic painful ulcer. If anything, they are always the later presentations of oral cancer. In these instances, lichen planus that transforms into mouth cancer are often very subtle and, very difficult for the patient to actually understand if that's actually occurred or not. So that's where that clinical surveillance is very important. And if the patient ever does sort of report, oh no, I'm fine, I don't need to, like if they're asymptomatic, for example, but they still have lichen planus in the mouth, it is important to definitely encourage the patient to have their ongoing checkups, because the number of times I have in fact seen these cases transform. Even in asymptomatic cases, it does happen. So please encourage patients to continue their clinical surveillance. With regards to managing their symptoms, usually topical steroids are first line. So topical creams, gels, ointments are used depending on the severity of the symptoms, even mouth rinses as well. Usually systemic prednisolone is only used to manage like an acute exacerbation. Having said that, in the instance of this particular patient presenting, if you did decide to use systemic prednisolone, that is also completely fine because it is quite an extensive presentation that the patient did present with. Now, if the patient is actually not responding well to topical measures, immunosuppressants can be used as well, and usually the specialist that is managing the patient will commence them on an immunosuppressant, whether it's a dermatologist or in conjunction with the patient's immunologist. That will be determined as to which way is the best protocol, but I just put this table in there for completeness as well. The next case is a 63-year-old female who presented with a 3-month history of progressive dry mouth symptoms and associated burning. She's otherwise medically fit and healthy. And when you assess her mouth, there is a bit of fissuring noted on the tongue, a frothy consistency in her saliva, and you also note a delay in the salivary excretions when palpating her salivary glands. So in terms of, I guess, investigations or what investigations you would run for such a case, the best way to understand or approach a dry mouth is in fact going through the process of history, examination, considering possible underlying causes and targeting your investigations towards that, then achieving your diagnosis and coming up with your management plan. So when someone does come to you complaining of a dry mouth, the first question you want to ask is it truly a dry mouth? Because patients can often just present with that subjective feeling of oral dryness that we know as xerostomia, without having the true presence of salivary gland hypofunction, which is dry mouth. And it is important to differentiate the two, because if you have ruled out salivary gland hyperfunction or a true dry mouth, but the patient is in fact suffering with xerostomia or dry mouth symptoms, it may in fact be a part of a different condition altogether. For example, it could even be a presenting complaint of oral dysesthesia, again, like what we discussed last week. So the first question is it actually a dry mouth that you're suffering with, or is it just the feeling of a dryness that you're complaining of? So with regards to the history, certain things that the patient may say to you and certain things that you want to look out for is complaints of, I have to sip water several times throughout the day or take a glass of water to bed. Other questions that you may in fact consider asking to determine whether it is in fact a dry mouth is, do you have difficulty swallowing your food? Quite often, patients with xerostomia alone will not have any impact on their function of swallowing food or feeling dry when they're eating a meal. So those are certain history-taking ways that you can determine whether there is a true dry mouth present or if it's more likely the subjective feeling of a dry mouth. Obviously, medications as well. A lot of medications are out there that have the side effect of dry mouth, so evaluating the patient's medical history and what medications they are on is very important. And then simple questions, assessing the patient's behavior. So are they in fact drinking adequate amounts of water? Are they having is their fluid intake in fact a lot more caffeine than it is water? And are they drinking alcohol, and are they a smoker? Again, further drying agents in the mouth. So this will give you a complete picture before you even assess the patient's mouth. Now, certain features of oral dryness really vary in intensity and presentation for a patient. So simply using either like your tongue depressor to see if it sticks to the mucosa is a way to determine whether there is oral dryness present. Other ways that you can also check for this is seeing if there is, getting them to lift their tongue to the roof of the mouth, and if it's all appearing quite dry and smooth, that is again another sign of oral dryness. Looking at the consistency of the saliva, so normally if you do notice any frothiness to the saliva, that's a clinical sign of oral dryness as well. If the tissues also appear really smooth and red and almost like the tongue is quite depapillated, are all signs of oral dryness. And it all sort of increases in severity. So if in a really dry mouth environment, you will actually notice significant fissuring of the tongue. In certain instances, you'll actually see food being stuck to their tissues because they're not able to clear it with the saliva. So these are all certain clinical signs that you can look for when assessing a patient complaining of a dry mouth. The next step after that is understanding the possible causes of dry mouth, and there are multiple. This varies from obviously salivary gland aplasia, which is developmental, certain autoimmune conditions, most commonly Sjogren's syndrome, but other autoimmune conditions as well that can manifest with dry mouth symptoms. Endocrine, such as diabetes and hypothyroidism. Simply anxiety can result in dry mouth as well, so you need to consider that from a patient perspective. Dehydration is one of the biggest contributors for a dry mouth. And then certainly, again, this is less rare to present, but it can occur, so you need to, again, take that into the patient context. Obviously, medications as well. It actually has been shown that two or more medications together, so if patient is on two or more medications, they're more likely to complain of oral dryness. And then obviously any history of cancer therapy as well is going to be a really big impact on their salivary gland function. So with all of this in mind, that is what's going to help you determine what investigations you're actually going to request. So a way to determine if a patient truly has dry mouth, so let's say they come to you complaining of dryness in the mouth, you look in the mouth and you don't in fact see any of those clinical signs indicating a dry mouth, you could consider taking an unstimulated or stimulated whole saliva test where you're actually measuring the amount of saliva they're producing in a certain amount of time. If that actually is reduced in quantity, then that is a clinical indicator that, okay, yes, there is a reduction in saliva flow. If your patient does in fact show clinical signs of dry mouth, so for example, our case, there was some fissuring of the tongue noted, there was some frothy saliva consistency as well, you can definitely consider some investigations to rule out autoimmune conditions and other metabolic conditions as well that can contribute to dryness of the mouth. If that comes back negative and the patient is still suspecting, you may suspect a salivary gland stone, for example, you can consider imaging as well in the form of ultrasound or CT MRI. Normally, ultrasounds are not adequate enough for picking up really small stones. So if you are ever suspecting a salivary gland stone, I would in fact go a CT scan over an ultrasound. And again, salivary gland biopsies can be considered, or even Schirmer's test, if a patient sort of comes back serologically negative for Sjogren's, but it is still suspected that they may have it. They can definitely undergo these additional testing as well. So these are the investigations that you could consider depending on the presentation of the patient. The next question is, what management options would you suggest to help her with her dry mouth symptoms? So again, the management is very much determined on the underlying factor for the patient's dry mouth, whether it's medication related. In some instances, unfortunately, the patient needs to be on those medications for their overall health. And in that case, you can't in fact change the medication, but you can definitely assist the patient with symptomatic management. In other instances, it may in fact be diabetes that was the underlying cause for their dry mouth, and so that will then result you into taking management for the patient's diabetes. With regards to symptomatic management, it really varies, and there is no hard and fast rule for a patient. So it really depends on what the patient finds most soothing in their mouth. And that can range from simple home measures, such as a really good quality olive oil or grapeseed oil that they can rinse out with, or they can consider using additional dry mouth products that are available as well, such as Oral 7, and this comes in different forms like mouthwashes and gels. You can also consider like the adhering tablets, which are called xylee melts. These are supposedly more longer lasting than the gels and mouth rinses, and they basically stick to the tissue inside the mouth and release moisture throughout. So again, there's no one product better than the other. It really depends on what the patient prefers to use. But these are certainly some good products that you can recommend to your patients. With regards to symptomatic management as well, you can consider the salivary stimulation. So that's something as simple as chewing sugar-free gum. The use of pilocarpine is not as highly recommended as it does come with other significant side effects like excessive sweating, etc. And quite often patients may have even underlying cardiovascular conditions, so it's not even indicated for them. And there are some other devices as well. These are generally saved more for patients who have undergone head and neck radiation therapy and their salivary glands are in fact no longer functioning. These particular devices can be used to sort of stimulate the salivary glands, but in general, chewing sugar-free gum is the most easiest way of stimulating a salivary gland. The additional measures that are important to consider as well is obviously advising your patient to reduce any excessive exposure to irritants. This is important because once you sort of lose that protection of the saliva, one, your oral tissues are more at risk of injury, so from trauma, and similarly in the sense of exposure to oral candidosis as well. So we discussed this last time. And with regards to caries prevention, so these are definitely important measures to advise your patients because, again, the patient's dental health will be significantly compromised with the lack of saliva protection. So regular dental visits, ensuring they're having a low sugar diet, ensuring they're using a fluoride-based toothpaste, and regular oral hygiene is also very important to enforce to your patient. The final case that we've included here is a orofacial pain case, and this is definitely a patient that can present to your clinic. So this particular patient is a young male, 26-year-old male, that presents with an acute locked jaw. He's complaining of sharp pain along the left side of the jaw and reports an inability to open his mouth properly. And he says that it happened this morning, when he woke up, and he woke up with a locked jaw. He's otherwise medically fit and healthy. What you note on examination is that his mouth opening is 32 millimeters, and there is moderate pain when you're palpating the temporalis muscle on the left-hand side as well as the masseter. But the pain is not in fact referring to a distant site. The left preauricular region is also tended to palpation, and when he does open his mouth, his jaw deflects to the left-hand side. You also don't notice any other particular jaw joint noises, and it's unfortunately too difficult to assess his left and right movements because he's just in a lot of pain. What are you going to do? So the first thing is, what is your clinical diagnosis? In this instance, anytime a patient presents with a restricted mouth opening, especially in an acute closed lock, it is important to try and distinguish, is this muscular in origin, or is this in fact a problem with the articular disc in the temporomandibular joint? The way that you can distinguish this is sort of understanding what in fact happens when we open and close our mouth. So this is a diagram sort of as a cross section of the TMJ, and I'm going to try and explain this as best as possible, but Sol, please jump in if there's any sort of clarification needed. So we're going to look at this first picture here. So this arrow is actually pointing to the articular disc, which is sitting nicely within the glenoid fossa. Now, when we go to open our mouth, our first 24 millimeters of mouth opening, the jaw joint or the TMJ is not actually moving much within the joint itself. So it's actually just rotating slightly. And what is actually happening is that it's your jaw muscles that are responsible for that initial mouth opening. So within the first 24 millimeters, it's all muscular. After 24 millimeters, you're looking at the disc being involved. So as you continue to open your mouth and you reach over 24 millimeters, you can see that the jaw joint actually starts to slide forwards within the jaw joint space, and the disc slides forwards with it. So if there is ever a restricted mouth opening that presents to you, measuring that mouth opening is important. If it's less than 24 millimeters, you're looking at a muscular issue as the predominant factor. If it's greater than 24 millimeters, you're likely looking at a disc problem that's going on. So the key points to check when a patient presents with an acute closed lock are, in fact, are the masseter muscles and the temporalis muscles, so the masticatory muscles, are they tended to palpation? Is the mouth opening less or greater than 24 millimeters? But is it restricted? So normal mouth opening is in fact 40 millimeters. Is there any jaw deviation or deflection? So generally, a mouth should open nice and straight. If the jaw deflects straight to one side, you're suspecting a possible disc issue. Similarly, if the jaw sort of moves to one side and then corrects itself, again, that could be a possible disc issue, but a different type of disc issue altogether. And can you in fact hear any TMJ noises? Is the patient aware of a TMJ click? Is the patient aware of any crepitation or crunching related noises? So in this particular case, your overarching differential diagnosis is in fact what we call a temporomandibular disorder. But this isn't in fact a diagnosis per se. And the reason why I've put this in here is to sort of make you aware that there are actually multiple different umbrella conditions that fall under the diagnosis of a temporomandibular disorder. So it is in fact a collective term for a group of musculoskeletal and neuromuscular conditions that includes several clinical signs and symptoms that involve the muscles of mastication, the temporomandibular joint, and the associated structures. So for this particular case, because the patient had a mouth opening of 32 millimeters, so it is restricted because it's less than 40, but it is greater than 24, we're suspecting a disc displacement. So in this particular case, the patient is suspected to have a left TMJ disc displacement without reduction with limited opening. They also have tenderness of the masticatory muscles, so a clinical diagnosis of masticatory myofascial pain can be considered. And because the patient woke up with this in the morning, a suspected underlying bruxism or sleep bruxism can also be considered as well. In terms of management for this patient, the key is in fact a prompt referral to an oral medicine specialist or a patient or facial pain specialist. But what are you in fact going to do for the patient though, because they are in quite a lot of pain? You can definitely get them to start on some of these conservative home care measures while they're waiting to see the oral medicine specialist, advising them to have a soft diet, being aware of any additional habits that can put further pressure to the jaw. And this includes simple things like clenching their teeth during the day, which a lot of people don't realize they do, especially in periods of concentration. Things like resting on their chin, so chin resting like this, or biting their nails and biting on the backs of pens and pencils. So simple habits like that are in fact putting additional pressure to the jaw. The use of heat pack and clock-mediated non-steroidals can be used, and also advising the patient to do some gentle jaw stretching exercises to target their masticatory myofascial pain. The additional thing that you can also consider while the patient is awaiting the specialist appointment, especially if you are suspecting a disc problem or what we call an internal derangement, is either an MRI scan or a CT scan of the temporomandibular joint. Ideally, an MRI scan is most useful when we're suspecting an articular disc issue, whereas a CT scan is more useful when you are suspecting arthritic changes. But either way, both would be extremely useful, especially while they're awaiting further assessment. The final thing that you can also consider taking is a psychosocial history. Now, the reason behind this is, in fact, there are 5 main risk factors involved in a patient recovering from their temporomandibular disorder. So generally speaking, majority of patients will improve with their TMJ dysfunction. They will be able to get back to what's called pain-free function, where they're able to chew and talk without any exacerbation of jaw pain. Patients, however, who suffer with underlying anxiety, depression, they have OCD tendencies, catastrophizing, or suffer with PTSD have actually been shown that their acute TMJ dysfunction can transform into a chronic jaw pain and chronic jaw problem. And it is important to identify this early because that's where patient expectations are set in. So this is something that you can definitely be a part of the patient's education and their reassurance as part of their treatment plan. And if you are able to identify certain factors like this will definitely be helpful for your patient in the long run. So overall, in this particular example, in an acute case, it is actually considered an urgent referral, but these are some measures that you can definitely take to help the patient along while they are waiting for their assessment with the specialist. So with that, that actually brings me to the end of the presentation today. So thank you again for having me, Sol, and for having me for the second time round. In this instance, I've put my email address as well if you have any questions, and I just put my little plug-in for the Oral MedMate app as well. So yeah, Sol, if you have any questions, I'm more than happy to answer them.
Fantastic. Yeah, look, wonderful presentation, Lalima. Look, as a GP, or as a medical practitioner in general, we don't really use our hands to palpate anything inside the oral cavity, which
Yeah,
is something I learned from this presentation, that as medical practitioners we still can put the glove on
yes,
and palpate, particularly the mouth or any oral ulcer using our
yes,
finger. That's a
yes.
habit that I'm going to introduce into my practice from now on.
Good,
A
that's
couple
great.
of other questions.
Yes,
With the syphilitic ulcers, do you
yes.
see them more around oral commissures, or can they happen anywhere in the oral cavity?
Yeah, they can happen anywhere in the oral cavity, but most commonly it would be the buccal commissures that they would present with, and especially in a primary sort of presentation, it's quite often a painless ulcer as well, so the patient has generally no idea that it's there, and it's only as the stages sort of go on that's when the pain comes into it. But any chronic ulcer, a differential could definitely be a syphilitic ulcer, regardless of the location.
The location.
Mm.
And the other question, I suppose, like you said, in some inflammatory conditions where we are not overly concerned about, malignancy, for example,
Yeah,
we perhaps, while we are waiting for the patient to see an oral specialist, we
yeah.
can perhaps, if you recommend, we can try some steroid mouth rinse. So my question is there any situation that you do not recommend even trialing the steroid mouth rinse? And if you want to order, is it only the compound one that you recommend, or can we just go with the topical creams and ointments or lotions? I've never prescribed, I'm asking too many questions at the same time, but I've never prescribed an ointment or cream in the oral cavity, even when
Mhm.
and correct me if this is a bad habit, when I'm treating the mouth office, I kind of tend to give the asthma inhalers, like the
Yes, the
Becklem,
Cuba.
like
Yep.
the Cuba, or any oral,
Yes.
any asthma steroid inhaler. And I personally feel it might be a better experience for them just putting the mouthpiece right over the ulcer.
Mm.
But I don't know how it tastes or how it feels. I've never tried and
Mm.
I've never prescribed. So a
Yeah.
few questions at the same time around the steroid use in the oral cavity by primary care physicians from
Yeah.
practical point of view. So
Yeah.
yeah, shine some light on it, please, for us.
Yeah, definitely. So yes, absolutely. If the patient is presenting, especially like even in the case that we saw, you can commence the patient on a topical steroid formulation. Now, it depends on the severity or the presentation itself. So, my recommendation is if the patient is suffering with quite multiple and generalized ulcers, so they're everywhere in the mouth, a mouth rinse, so like a compounded mouth rinse, or simply the patient can actually crush and make that formulation themselves. So for example, to get that concentration, you can get the patient to crush like 5 or like, a total of 20 milligram dexamethasone in 200 mils of water, and that's a mouth rinse made up in that formulation, and they're rinsing out 5 mils of it. Um, the mouth rinse form is quite helpful when there's, generalized ulcerations. If it is a single ulcer, for example, and you're still thinking that it's inflammatory in nature, that's when a ointment-based is a topical steroid ointment can be considered as well. So then the rest of the oral mucosa is not, in fact, exposed to the steroid. And you can consider using a variety of I guess, concentration. So it can really vary from your simple zero point 0.1 betamethasone valerate. Now, these are all technically off-label use, and sometimes I've had problems with pharmacists not actually dispensing it as well because they aren't, in fact, aware that this can be used. So that's like a whole another problem in itself. But it definitely can be used intraorally, and you're advising the patient to apply it directly onto the ulcer 2 to 3 times a day. If they want, they can apply a bit of gauze as a gauze occlusion as well to keep it in place, because quite often one of the biggest complaints with ointments or cream-based steroids is that it mixes with the saliva and patients don't feel like it's going to the right spot. But generally speaking, they do find it quite easy to apply. The steroid puffers are also an adequate option. It really, again, depends on where the ulcer is. So if the ulcer is an easy place to get to, that's when patients can definitely, do 2 puffs to that particular spot, again, 2 to 3 times a day. But what I often find, or I guess the population that I deal with as well, it's quite hard, like dexterally, to get to that particular spot. And that's where an ointment-based steroid can be definitely more useful rather than trying to get the puffer in the right position on the ulcer itself. But all options can definitely be considered, even if the patient's waiting for a formal diagnosis.
So with the ointment, do you prefer ointment over cream, or
Yes, yeah, ointment over
so the
cream.
so with the ointment,
Yes,
practically you get the patient to pop some over the finger, put
yes,
it on, and
yeah.
then they need to wait for some time and then spit it out, or
Yeah, so the instructions are essentially just a small pea-size amount. They can consider drying the area before applying it. It's not necessary as long as it's still in the right spot. And they apply it to the area, and then they don't eat or drink anything for at least 20 minutes after the application. So nothing should be going in their mouth at that point. After that, whether they wish to spit whatever is out, that's absolutely fine. But generally by then, a lot of it, they've usually swallowed a bit of it anyway. But it's just a very
Mhm.
small amount. So it's the pea-size amount that they're applying. It's not like a big strip that they're putting on the area.
Fantastic. All right. Look, that's a good thing we can try in a sort of an emergency situation where the
Yep,
patient is suffering, and
definitely.
not all of us have timely access to specialists like you.
Yep,
So at least we can try something while we are waiting.
yep.
Fantastic. Thanks again, Lalima, for another wonderful presentation full of learning points for us. I really appreciate your time.
Thank you. Thanks so much for having me.
Thank you so much. And hopefully we can see you again sometime soon in our forum again.
That'll be great. Thanks.
Cheers. Okay, bye.